Good afternoon, my colleagues. Let's start our first genitourinary system Viva cases. Before we start, I have some pieces of advices. Please, my colleagues, try to be concise and describe your case in very short bullets related to the case and the history and to the main pathology. And please avoid too much verbosity because it is very annoying for the examiner. So you must describe your finding in a less time as much as possible. Second point, you must immediately tell the examiner the differential diagnosis. Don't let him ask you. Third, you must, after that, tell him what is your management or your next step, either radiological or non-radiological, or what referral will you do to which MDT. Please try to proceed the examiner by one step. Don't let the examiner ask you. If the examiner asks you, this is means you will lose mark. Okay, my colleagues. Uh, I should it should be like this, your style. Let's start our first case, 55-year-old male patient. I will first start with the ultrasound. As you see here, this kidney shows dilatation of part of its calyceal system, either the lower part or the upper part, here associated with ureteric dilatation. Okay, my first candidate. This is this is the CT. This is the CT of this patient. As you see,
Sir, can I see the coronal images, sir?
this is coronal images.
I think I have to request. Yeah, control again. Sir, I have requested control again.
Yes.
Thank you, sir. In the excretory phase images, coronal phase, there is contrast excretion in left kidney as well. With dilatation, ureter appears dilated. I'm looking for any filling defects within. I could not appreciate any filling defect. I'm looking for any duplex collecting system. Yes, I can see a duplex collecting system with lower pole is not dilated. So this might be associated with bilateral. There is bilateral association. So I am ruling out. I'm sorry, sir. I'm not able to scroll well.
Leave the mouse. I will scroll.
So I'm trying to look whether there is a duplex collecting system on the right as well.
Yes.
Yeah. I think there is. Yeah, there is a duplex collecting system on the right.
In the right or in the left?
There is left. There is duplex collecting system on the left with obstruction in the upper moiety.
Yes.
In the coronal images, I am not very sure whether there was duplex. I'd like to confirm it on axial.
So conclude, please.
To conclude, sir, this is a left-sided duplex collecting system on the left with obstruction of the upper moiety with associated pyelonephritis.
Where is the pyelonephritis? Could you indicate? Where?
Sir, there is some alternate, some decreased enhancement in the parenchyma. Here, upper and endopolar region.
What about the pre-renal fat, pre-nephric fat? What happened?
There is significant fat standing.
Yeah, so not too much significant. Yes, okay. Excellent. So
these are in favor of obstruction with pyelonephritis.
Okay.
I would inform my findings with the referring clinician to confirm about the lab markers, whether there is any features of infection, and the patient would require a urology opinion and probably discussion about putting a percutaneous nephrostomy tube. Thank you, sir.
Thank you so much, doctor. You did very well, but take a home message. This is the ultrasound here. Actually, no obvious air, really. Just a
Okay, sir.
dilatation in one part of the calicell system. This is considered upper or lower because no markers here. The middle calicell is normal, the lower is normal. This is the fat, central sinus fat. This is not an
Okay,
air.
okay.
This is not a stone. Why? Look behind it. No shadow, either dirty shadow or
Okay.
clear shadow, but overall no shadow. Here also like this, and يعني you did very well when you pick up. There are some dilatation here. Okay, then you did very well really when you pick up this dilatation and hypodensity. Doctor, I wanted to ask you one question: how to differentiate between the pyelonephritis and infarction? What is the differentiation point? Could you know?
Sir, in pyelonephritis, the cortical rim sign will not be present. But in
Excellent. Excellent. But tell me.
infarction, there might since there is an early arterial which is arising from the renal artery, it might there will be thin contrast rim of contrast enhancement along the cortex.
Thank you, doctor. You are correct. You make
Yes.
another mistake here when you go up and down. Go up and down. See my colleagues, you when you catch the mouse, have a look. You can have a look slowly, okay, or rapid as you like, but don't go and down. It is very irritant. Okay, go down, down. And when are you going down, please, يعني don't be silent for a long time. Till
Okay, sir.
please talk about the technique. Please talk about the most prominent pathology you see. Then, then you can or you validate it to stop and talk too much about the main pathology, like here. Okay. Third point, you didn't ask me. You told me I want a coronal, but fortunately, this coronal was in the excretory phase. You are
Yes,
lucky.
sir.
You better to ask me, doctor, please, could you give me the excretory phase? Okay. It's better to be asked like this. This is a two ureters, one of them markedly dilated and connected with the upper moiety here. Okay, and this is the cause of pyelonephritis. And this ureter has ectopic. The upper ureter has ectopic insertion in the bladder, the upper moiety ureter. Okay, and here there are obstruction, the obstruction here. So there are subsequent marked hydroureter nephrosis. But the lower ureter, the lower ureter or the lower moiety ureter has the orthostatic or the normal insertion in the trigone, where we can see here. Okay, here. This is the upper moiety. This is the lower. Okay, the upper ureter here markedly dilated due to the pathology here almost stenosis because this is an ectopic insertion in the bladder. Sometimes it inserted in the neck of bladder. Um, it is inserted not in the correct position. The correct position should be in the trigone here. Okay. Um, Second point, you must check the other ureter, which of the lower moiety, because sometimes there are some reflux and it may be dilated, but in this case it is normal. The management in this case, do you think this patient need a first line of treatment nephrostomy tube? I didn't think so, really. Why? Nephrostomy tube, يعني better to start with antibiotic because we don't know if this
Okay.
pass or not. Better يعني better to start with antibiotic. Okay. And you can
Okay.
okay يعني you are not incorrect. But يعني you can tell better, doctor, he may need a nephrostomy tube if the condition worsen. Why? Because look at the history, fever, left-sided pain. The patient is not a severe case. Yeah. So I think he is not a severely, there are no obvious Bionephrosis. If do you know if there are a bionephrosis here, you can't see a healthy kidney like this. You can't see like this. What is the signs of bionephrosis here? Bionephrosis, sorry. You will see this pelvic calcium system markedly thickened and enhanced, and here may be some septation, marked turbidity. Okay, but overall you did
Okay.
very well. Thank you, doctor, so much. It
Thank you.
was a case of complete duplex collection system with pyelonephritis in the left side. Thank you so much. Next candidate.
Yes, sir. Good afternoon, sir.
Welcome. 1 second. I think this 65-year-old male patient. The patient presented to the emergency department complaining of body aches and oliguria. 65. Can you scroll? Shall I scroll for you?
Yes, sir. I requested for the remote control.
Okay, go on.
Here I am presented with the ultrasound images of abdomen of a old age patient who presented with the oliguria. I am
Yes.
I am predominantly the spleen looks normal, uh, and the left kidney that looking me slightly enlarged in size, and echogenicity is also altered, and the sinus fat is mild echogenic with adjacent fat stranding is there.
Mm-hmm.
And the right kidney, the right kidney is also bulky with perinephric fat stranding is there, and there is a altered echogenicity area is noted uh, at the upper pole of right kidney, and
Yes.
there is a echogenic focus is there in the kidney that can be the calculus, but it is not showing any distal acoustic shadow. And there is
Yes.
mild hydronephrosis is also present in the right kidney. So, uh, putting it all together, the patient presented with the pain and the oliguria. So, and with there is a perinephric fat standing in large kidneys are there, and heterogeneous echogenicity area in the right kidney. This can be case of bilateral pyelonephritis, or and there may be some SOL at the upper pole of the right kidney that can be the developing abscess. That can be one possibility. For the confirmation of my finding, I will check the lab parameters and the previous imaging and the history of detailed history of the patient and go for the CT scan of the patient if KFT are normal.
Okay. This is a CT scan.
Here I am presented with the non-contrast CT scan of the chest and abdomen of same patient. In this, my target area is over right kidney to look that heterogeneous signal intensity area. Yes, in this I can see I confirm my aforementioned finding. There is bilateral bulky kidneys are there, perinephric fat standing is there, as well as dilatation of the right collecting system is also there. Uh, I am looking for any calculus because right side hydronephrosis is there. Uh, uh, Patient is a old age patient. There are atherosclerotic changes are seen in the abdominal aorta and its branches.
Doctor, what's your differential diagnosis? Tell me what's in your mind.
Yes, so this can be pyelonephritis is my first diagnosis in this,
Please
and
look again to both kidneys. Look again, look again. Hmm. Again. Do you want to see any other sequence, doctor, or any other stage?
I want to see the contrast images.
So ask me, please. See, this is the
Yes,
venous. What do you
yes,
think? Is this kidney, both kidney sizes are acceptable for you?
yes. Both kidney are enlarged in size, and the liver and spleen is also enlarged in size.
Okay.
I am
So,
checking for the, so that can be case of the infection can lead to the enlarged kidneys, and one more thing, the lymphoma can be, but there are significant fat standing is there on the both kidney, so the lymphoma is less likely.
why? Why, doctor? Doctor, why? Why? Do you think the infection will cause this
Mhm.
bilateral, nearly symmetrical enlargement? Okay. In
Okay.
in pyelonephritis, there are a characteristic appearance of both kidney. Do you know it? Do you remember?
Yes, there will be striated nephrogram will be there.
Okay, let's see here. At least there are any
And
striation here.
yeah,
Unfortunately, we didn't have secretophase. Do you think
I am
it
checking.
may be striation? Hmm?
Yeah, yes, that at the lower pole of the right kidney looks heterogeneous in this phase. I will check the delayed images
No,
as
no, no,
well.
doctor, be with me, be with me. See, you said there are bilateral enlarged kidney, and there are at least bulky liver and spleen. You are very correct. Okay, what about the stomach? Could you think this stomach is normal?
Stomach bowel wall thickening is there in the stomach, but it's a collapsed lumen.
Yes, excellent. Is there are anything else here? Could you
I am
detect
checking for the lymph nodes. I am checking
anything?
for the lymph nodes.
Could you find any enlarged lymph
Some,
nodes? Hmm.
yes, there are few lymph nodes are there in the prepararotic region.
So give me your first differential diagnosis, please.
So yes, so in the old age patient, bilateral symmetrical enlargement of the kidneys. So
Yeah, not
that can be
symmetrical,
the,
but okay. Okay.
so that can be due to the lymphoma. That can be one possibility because enlarged lymph nodes are there. If the patient is immunocompromised, then it can be the HIV associated enlarged kidneys. That can be one
Okay.
possibility. And
Okay. Okay.
other
Yes. Yes.
because
What's
there
your
is no
what's what's your next step?
uh, next step. I will check the delayed images as well in this.
Okay. To which MDT you will refer the patient, doctor.
The patient should be referred to the nephrology MDT and the nephrology MDT and the nephrology MDT and the oncology MDT for further evaluation, and the renal biopsy can be done.
Thank you, doctor, so much. You did very well. My colleagues, the ultrasound and the X-ray is a limited study in our Viva exam. So what is required from you to pick up a general idea? See, if you told the examiner, this kidneys looks like enlarged, you are very good like this, and there are minimal pelvic LCL system dilatation or fullness. This spleen looks like enlarged. I would like to do CT. This is a CT. Before going inside or before going inside the exams and giving a definite diagnosis, ask the patient, the mistake, what you did. You look at the non-contrast and then give me a definite diagnosis. This is impossible. You were very sure that, oh, doctor, I can exclude lymphoma. Why? Ask first for others. You look here, you find these kidneys are no, abnormal. Why? Look, most of the posterior half of the abdomen, see, if we divided the abdomen to anterior half and the posterior, the kidney really occupying the posterior half. Look here, look here. All the bowel are displaced either anteriorly or in the middle. the kidney looks like enlarged in size. Okay, the kidney here, this is the arterial. Then there are no definite focal lesion. So, and the second point, really, the fat is not smudged, just very minimal blurring. Okay, where is the clue here? This is the clue. Okay, till now, okay, bilateral enlarged kidney for differential. Differential diagnosis like what? Number one, lymphoma. Number two, this is nephroblastomatosis. Okay, if you tell the examiner like this, you are brilliant. But tell the examiner, doctor, I want to search for any enlarged lymph node. Oh, doctor, there are wall thickening of the stomach. This is the not. This isn't the normal collapsed stomach. At least there are thickening here. And if you go down, you will find this is a lymph node. Okay, you will find a very aortic, very mesenteric, some lymph nodes. Okay, this is lymph nodes. Okay, doctor, this is almost a lymphoma case. You will be very excellent, even if it is, for example, another tumor, but at least this is a tumor case, not an infection case. Okay,
Okay.
this is very important, my colleagues. Try, if you pick up something, try to search for another clue. What is the function of the other clues? Either to exclude a differential or to prove a differential diagnosis. Okay, my colleagues. Thank you, doctor, so much. The liver and the spleen has no metastasis. Even the lung is show no metastasis. A tricky point here, my colleagues. See, this is not an abdominal only X-ray. This is chest, abdomen, pelvis. So be aware. Be aware, please. This is where when we do chest, abdomen, pelvis in cancer cases or in oncology cases. Okay, sometimes
Okay.
the technique will inform you something about your differential diagnosis. Okay, my colleagues, thank you, doctor, so much. Next candidate,
Good afternoon, sir.
welcome, doctor. 1 year female patient. The clinical examination of the child reported a palpable mass in the left groin.
Okay. I've been provided with MRI images of a 1-year-old child with a palpable mass in the abdomen. There is evidence of multicystic lesion seen in the left renal region. I'm just trying to look for the kidney. Uh,
Can you scroll, please? Can you scroll?
yes, sir. Yes, sir.
Requested.
Trying, sir. Okay, sir. Sir, requested.
Go on.
Yes. Not able to scroll. Okay. So not able to scroll. Okay.
Okay,
I'm not able to
I'm scrolling
visualize
for
the.
you.
Okay, sir.
I'm
I'm not able
scrolling
to
for you.
visualize the left kidney separately um,
Yes.
from the lesion. Yes, I can see the left kidney being displaced superiorly.
Yes.
The pelvic electrical system of the left kidney also appears dilated. Uh, this appears to be arising from the lower pole of the left kidney.
Yes.
The lesion appears T2 hyperintense. I'm trying to look for any other lymph nodes. I would like to look at other sequences, T1 weighted images, if any.
T1. Are you sure it's T1?
Yes, sir. Yes, sir. On T1 weighted images, the lesion appears heterogeneously hypointense. There are few hyperintense areas within which could represent hemorrhage.
Okay, excellent. What
Uh,
sequence you want? Which sequence?
so I'm
See,
looking
we
look
don't
at
have We don't have post contrast.
Um,
We have diffusion.
yes,
This
sir.
is a diffusion.
On diffusion wasted images, there appears to be a hyper intense signal, but I would like to correlate it with the ADC images.
Okay, this is some hyper high density, high DWI. Okay, what's your
Okay.
differential diagnosis, please?
Um, Based on these images, my first uh, diagnosis would be that of a mesonephric blastoma in a
Okay, what
1-year-old.
else?
This could also be uh,
Hmm. Yes, yes. What else?
multicystic nephroma. Multicystic nephroma.
Excellent, excellent,
Um,
excellent.
yes,
Okay,
yes, sir.
okay. What else?
Uh, if the kid would have been, the child would have been a bit older, this could also be Wilms
Mm-hmm.
tumor.
Mm-hmm.
Uh, uh, and
Okay,
other less likely differential could be a neuroblastoma.
okay.
But
Thank you, doctor,
the
so
lesion is
much.
cystic.
What?
Yes.
What? Tell me, like I told you in the beginning, what is the management?
So I would like to inform these findings to the referring physician and refer this patient to the pediatric oncology team for further
Thank you,
evaluation with
doctors.
the biopsy.
Thank you, doctor, so much. My colleague, this is a case of pediatric cystic nephroma. Unfortunately, we didn't have any post contrast, but if you look here in T1 even, only we have some hemorrhage, no any solid component could be detected, even in the diffusion with the image. Okay, and this is the criteria of the pediatric cystic nephroma. The other differential diagnosis, be intelligent. See, this is completely cystic, multicystic lesion with sensitivity, causing some, I think here, some hydronephrosis. Be intelligent. When you are aiming to tell the examiner about the differential, tell him the most common tumor in the pediatrics, like Wilms tumor, like, but which Wilms cystic form of Wilms tumor. Okay, multicystic dysplastic kidney. Like this, the examiner will be happy. Okay. Anyway,
Okay, sir.
I just wanted to revise with you some pediatric renal tumors. Thank you, doctor, so much. The pediatric cystic nephroma characterized by absence of solid components, okay, or even
Okay. Thank you, sir.
any peripheral mural nodules. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Yes, sir.
The
Hello. Good
welcome.
evening.
Hello.
Yeah,
Good evening.
candidate 5 years, sir.
Eh,
Good evening.
1 second. Even the neuroblastoma, okay, you can include here, no problem. But almost the neuroblastoma will not be like a cystic like this. It should contain calcification, and the other criteria that all of us will know and know it very well. Uh, let's go, doctor.
Yes.
This patient has
Mm,
abdominal pain. Abdominal
mm,
pain.
okay. Uh, I requested for the control.
Yes, yes, please.
Mm, yes, sir. I have been provided with a CT scan of the abdomen in portal venous phase. Uh, dragging and plus is come.
Yes,
Is it? Uh,
leave the mouse. Leave 1 second. One
yeah, yeah.
second.
Okay,
Use the arrow.
okay.
Use the arrow. Use the arrow.
You use the this one. Okay. The arrows.
Yes, yes.
Okay. Yeah. Okay. Okay. Slowly moving now. Yeah. So just I'm going back again. Yeah. Liver. I'm looking at the. Okay. Lag is there. Sorry. There is. I noticed the first striking abnormality. I noticed that there is some lesion, hypolucent, lucent lesion, hypodense lesion is noted in the right adrenal gland. Apart from that, also I noticed that there is a heterogeneous lesion is noted in the right kidney. which is predominantly hypodense with an area of contrast plus within it. The pelvic axial system is collapsed, and this is extending to the lower pole. So the hypodense lesion.
What else?
Yeah.
What else?
The hypodense component is filling the pelvic axial system. I'm trying to see the pelvis. Yes. Do we have, sir, the post contrast? I mean the excretory. I would like to see the excretory phase images also. Sir, there is a big lag. Is not responding. I'm scrolling down to see. Okay. Yeah. In the bladder also, I noticed that that there is an abnormal area of growth enhancement is noted along the posterior wall of the bladder, and maybe involving the vesico-ureteric junction. I'm looking at the frame. Okay. So with there is the heterogeneously enhancing mass in the along which has papillary type growth on the posterior wall of bladder, which is
Are you
enhancing. So
sure,
this is concerning for
doctor? Doctor,
yeah.
are you sure this is
Mhm.
enhanced mass? Are you sure?
Faint enhancement is there. It's a slight hyperdense. It's faintly enhancing. It appears to be.
I didn't.
Maybe
I
then
didn't.
yeah, other hmm.
I didn't give you
Okay,
the
sir.
pre-contrast. Okay.
Okay, yes, sir. I should, yeah, in my routine practice, I should compare with the previous pre-contrast. And second thing, it is dependent, so it could be a hematoma also in the dependent
Okay.
location.
Look here, doctor.
Mhm.
What happened?
So, yes. So,
What happened here?
yeah. Here, there is a blush of contrast is noted within the corticomedullary junction with adjacent hypodense lesion. Yeah. So, this could be some lesion with a possible pseudoaneurysm formation within the kidney.
Okay.
Well,
Look here.
I'm thinking, yeah, okay, sir. In the
What
coronal view,
happened?
I noticed that pelvic axial system. Again, I noticed that there is a contrast outpouching is noted
Yes. What
with
happened?
adjacent lesion.
Yes. What
So
happened?
this this could be some vasculitic process causing the inflammation and secondary pseudoaneurysm formation in
What
the
else?
kidney.
What
What
else?
else?
Look here. Can
It,
vasculitis cause this
mm,
linear non-enhancing tracts?
mm.
Here.
Okay.
What happened?
Yeah, other
What
possibility it
history?
could.
What history should you ask about?
eh, Possibility of infarct is there, so I should ask about any thrombotic state or anything.
No
Yeah.
history of thrombosis. What
Mhm,
else? This is see, doctor. This is a
Okay. Yeah.
localized
Uh,
pathology. Hmm.
okay. Other possibility I should ask of any instrumentation has been done like biopsy. However, it is usually done on the lower pole, so that also unlikely for
What
instrumentation.
else? What history? You are very near. What history you wanted
Okay.
to ask about?
Uh, uh, any test, any other known malignancy is there because involvement of
No,
adrenal
no,
was
no,
also
no.
there. Okay.
See. There are a
Mm-hmm.
pathology here
Mm-hmm.
and the localized pathology here.
Yes.
And you said
Yeah.
there are
Mm-hmm.
almost a hematoma in the bladder.
Yes,
What
sir.
pathology? What is the scenario of this case? What happened? So all of these
Okay.
circumstances occur.
Other could be apart from granulomatous disease.
Doctor, this
Mm,
patient
mm,
has
mm,
come
mm,
in the
mm.
emergency with acute
Yes.
right-sided
Okay.
pain due to something.
Okay.
What
Yes, sir.
history you
Yeah.
should ask
Then
about?
it other is of the trauma, history of trauma with
Okay,
laceration of the kidney. Yeah.
okay.
Yeah,
The
there
patient
could be
has a
possible.
history of
Yeah.
trauma.
Yeah.
Mhm.
With this finding, with the laceration extending from the capsule to the calyceal system, this is a grade
Yes,
3 trauma, and with
yes.
of course
And
with this is an
what is
hemorrhage and
this? What is
aneurysmal
this?
formation also. This
No,
blast of contrast, active hemorrhage.
not active hemorrhage. If
Mm,
this active hemorrhage you can see
mm,
outside.
mm.
outside.
Okay.
But what happened
Yeah.
here? This is an injury to
Uh,
an artery. So what is the name of this? Post-traumatic dilatation of the artery.
uh,
Pseudo
and pseudo
aneu.
aneurysm formation. Pseudo
Okay,
aneurysm.
and
Yeah, I told sir. Yeah.
okay.
Pseudo
And
aneurysm
what
formation
happened
is
for
possible.
the suprarenal?
Mm.
What happened for the suprarenal here?
Suprarenal also has a collection within it, hypodense collection. This could be because of adrenal hemorrhage within the
Okay.
adrenal.
Thank you, doctor,
Yes, sir.
so much. But you didn't tell me your next step, your management.
Yeah, yeah, sir. Yeah, yeah, sir. I will so with this trauma, this is an urgent case. I will immediately inform to the surgical team as this is a grade 3 AAST injury. So for the further all for the bleed for the pseudonym, I will also inform the IR team for the embolization of the said artery, and also mm, uh, follow up may be required for this. Follow up
Thank
imaging
you,
will be
doctor, so
required.
much.
Yes, yeah, yeah,
Thank you, doctor.
yeah.
So
Thank you, sir.
my colleagues, many candidates will not tell you the full history because if I told him this is a trauma, يعني I give him 50% of the diagnosis. Okay? Leave the mouse, please, doctor. Leave the mouse.
Yes,
What
yes.
happened here? You find something localized here only in one kidney, in one part, almost on the upper half. Okay? So think in localized causes. You did very well when you talk about the biopsy. Okay? And what about the trauma? This is a classic trauma case, grade 3. Okay?
Yes.
So there are a suprarenal hypodensity, likely hematoma, and there are two tracks here.
Okay.
See the laceration, my colleagues. Then laceration.
Okay.
Then
Okay.
this is not a blush. This is a collection of contrast. This is a pseudoaneurysm. Okay, and you
Okay.
forget to tell me about this type of this hydronephrosis. What is the cause of hydronephrosis here, doctor? Could you tell me?
Sir,
See the
yes, sir.
hydronephrosis.
The thrombus within the excretory system, collecting system in the ureter will cause this one. Thrombosis,
Thrombus or
thrombus,
hematoma? No, 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 no. No, no, no.
uh, uh,
Thrombus or hematoma? Big difference.
hematoma, basically. Yeah, hematoma, basically hematoma.
Hematoma.
Yes.
Okay, okay, okay. Take some home advice, doctor. In
Yes,
all
sir.
trauma cases, my colleagues, we must ask the examiner for delayed or excretory phases. We must. And we
Yes.
should tell him, doctor, we want to rule out any collecting system injury.
Sure, sure.
Okay, if I
Okay.
see contrast outside spilling here, there are a collecting system injury, and it will make the degree different. Okay. Second point, you didn't ask me about the bone window at all, because despite يعني I stress
Okay.
in this the history that is a trauma case. This is very important, my colleagues. Very important. Okay, and then you didn't comment in the major vessels, aorta, IVC, like this. I think this patient may have a fracture if we see. I think this is a fracture here. This is a fracture.
Yes, in the
He
rib.
has a fracture in the rib. Yeah, see. All this point. See. He has a fracture here. Hey, 11 rib. Right? 11 rib. This is very important to my colleague. Why? Because this rib will, this is a fracture here, will cause him later on a pneumoperitoneum, a pneumothorax, maybe tension pneumothorax. So all of this will at least tell the examiner, at least, tell him. If he give you open window, okay, you are in the safe side. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Yes, sir. Hi.
Hello, 50-year-old male patient presented with bilateral flank pain and distension. 50 years old.
Okay. Sir, I have asked for the remote
Yes,
control.
please. See, 1 second. Leave. Use the arrows. Use the arrows.
Sir,
Scrollable.
I'm use.
Use the wheel or the arrows.
Yes. I'm using.
Movable.
Yes, I can. I think yes, I can.
Movable. Let me scroll for you.
Okay.
Go on.
I have been provided with the axial CT images of an abdomen, post-contrast images, portovenous phase of a patient, 50-year-old patient who was presented with a complaint of bilateral flank pain. Looking at the images, I can see there is a large fat-containing lesion with significant vessels within it, noted in the left side of the abdomen. Um, which is significantly displacing the kidney inferiorly.
Yes.
Uh,
Yes.
so this and I have to look for if there is. I am thinking of renal angiomyolipoma, and I have to look for if there is any active bleeding within the abdomen or hemoperitoneum, which could
Excellent.
suggest that this could be due to a
Excellent.
rupture.
Okay.
I have to look for the right kidney. I can see the fat density also noted within the right kidney as well. So this is also
Yes.
suggestive of bilateral renal angiomyolipoma. Um,
Yes.
and so with the bilateral renal angiomyolipoma, I have to think of tuberous sclerosis. So I have to also look the lung to see if there is any involvement of the lung or to rule out lymphangiomyomatosis.
Okay. What else?
And also, I want to see the axial images to see if
This is axial.
yes. So I have to look for the to see if there is any evidence of pelvic alysis system dilatation. The pelvic alysis system appears normal. Um, there is significant fat strandings noted within the abdomen. I could
Yes.
not
What's
find
your
any.
differential? What's your
Yes, so in
differential?
summary, I'm thinking of bilateral renal angiomyolipoma. The left one is quite large, so this require urgent consultation with IR team for embolization, and further I look the lung window to see if there is any involvement of the lung, and also see the bone window to see if it's sclerotic foci within the bones, and also recommend first I will inquire if the patient have a known case of tuberous sclerosis. Definitely the patient have a further imaging. Otherwise, the MRI of the brain and the whole spine can be done to see involvement of the brain and the spinal cord.
Thank you, Dr.
And
Roshni, so much. You are
for the
amazing.
screening of the
Thank you. Thank you so much, doctor. This case of large exhibiting left angiomyolipoma. But if we look to the rest of both kidney, there are multiple bilateral angiomyolipoma. So we are talking about almost tuberous sclerosis. Till here, there are bilateral multiple. Okay, I don't know why this lesion left until this age. Patient is 50 years old. Okay, but however, that is the case. Okay, you did very well, Dr. Roshni. This patient need for consultation, but you forget something here, only left inguinal hernia. Okay, and this is a one case of satisfaction of search. Very important, despite this not strangulated or complicated, but it is important to be mentioned because it is very clear. The patient
yes, sir.
should be done underwent an MRI. You can also tell the examiner, doctor, I didn't see any ventriculoperitoneal shunt. This is a very good sign from you. So, but however, I wanted to do either revise his previous images or to do screening. Thank you so much, doctor. Next candidate.
Hello, sir. Good afternoon.
Next again. Good afternoon. This patient has abdominal pain. Okay. He
Okay.
have only limited axial and coronal images.
Okay. Can I request the control, sir?
Yes, please. And by the way, he have a recent procedure. Go on.
Okay. Thank you, sir. So I'm presented with contrast enhanced images of the abdomen of a patient who had presented with abdominal pain with a limited history. So I'm taking a moment to scroll through the entire series of the image. The striking abnormality I can appreciate in this arterial phase imaging is multiple enhancing lesions randomly distributed throughout bilateral lobes of the liver, with the largest one being in the right lobe in segment 8, which is showing heterogeneous heterogeneous density with necrotic areas within, and the liver is also enlarged in size and is showing heterogeneous attenuation in this arterial phase image. These multiple images within liver are looking like metastatic lesions to me. In addition to the liver lesions, I can see there are multiple heterogeneously enhancing, predominantly hypodense lesions in spleen. Few of the lesions are exophytic in nature. Even the liver lesions, some of the lesions are exophytic. So I'm worried if there is any rupture of these lesions causing hemoperitoneum or not. However, there is no significant hemoperitoneum in this imaging. Another abnormality I can appreciate is in the form of diffuse hypoattenuation in the left kidney, which is appearing slightly bulky.
Okay, what else?
Without definitive
Look again
lesion
at
in
the
the
look again at the left kidney. What else?
Yeah, I'm looking again at the left kidney. So because it is diffusely attenuating, I'm just trying to look after the left renal artery. So if there is any possibility of infarction is
Leave
there
the
or
mouse.
not.
Leave the What happened here? What happened here?
So I in the renal pelvis, I can appreciate a heterogeneous enhancing lesion. So I'm
Doctor,
suspecting there is any lesion in the renal
listen to me.
pelvis.
Listen to me. You take too much time about describing these lesions without telling me what is the process. What are you dealing with? What are you dealing with? What case scenario of this? Multiple liver and
Yeah,
spleen. What is this? Tell
metastasis
me.
with
Okay, very
yeah. I'm
easy.
looking for the
Yeah,
primary.
very easy.
Yeah.
See, you take about 3 minutes without telling the examiner, okay, doctor, this is metastatic. So you should
Yes.
tell. Then I give you this a dedicated single slide. What happened here? Don't describe more about the metastatic nature in this left kidney, because the case scenario is very clear. When I ask you,
Hmm.
so there are something dangerous, new, important for examiner. What happened here? What's the name of this stage?
So the left renal lesion is at the level of a renal hilum.
Doctor, this is ACT in arterial or venous or delayed phase.
This is CT in the late arterial phase. I can see portal
No,
veins also, so it is in portal venous phase.
no, not delayed, doctor. Not delayed. Second question. What is this?
Yes, sir.
What is this?
On the left kidney, sir.
Yes, what is this? Hello, doctor.
I cannot appreciate, sir. In the left kidney, there is a lesion which is in the
Doctor,
renal
yes,
pelvis.
yes, yes. What is the name of this structure? Please tell me.
So I'm thinking of transitional cell carcinoma, which might be
No,
involving the
doctor,
left renal
doctor.
pelvis.
Something come from the left kidney to the IVC. What is the name, anatomical name of this? By the way, this is
Yes, sir.
not a delayed or late arterial. This is arterial, normal arterial.
This artery.
What is the name of this structure?
So this is a left renal vein, which is leading
Okay,
into the left.
when you see the left the renal vein in the arterial phase. What happened here?
Yes, sir. Yes.
What happened between the
So
artery and the vein?
there is a fistulous communication between the artery and the
Okay,
vein.
thank you, doctor. Thank you, doctor, so much. This is a case of 2 minutes, my colleagues. Why I bring this case? I want all of you to eliminate our verbosity. Okay, very limited history and a very limited number of slides. Okay, we see here, this is no need too much verbosity, my colleagues. This is metastatic. Okay, we should say this is a hyper enhancing variable size and shape, widely spread lesions, markedly enhanced in the arterial phase, involving kidney, involving liver, most of the liver, and to lesser extent the kidney, the spleen, and there are some lung metastasis here. You didn't speak about it. And this is important. So, my examiner, this is a case of metastasis. When the examiner gives you a very obvious case, you should know that there are something hiding here. Okay, I didn't bring this case for this metastasis. I bring for this. The patient, and I told you from the beginning, if you look here, I see, there are a procedure here. And I told you the patient did a procedure. At least look here. When you didn't know, I stopped you here. Renal
Yes,
vein
yes.
in an arterial phase. So there are a fistula. The main
Yes.
cause of this case, or the main target, to detect this renal arteriovenous fistula after a biopsy. Thank you, doctor, so
Yes.
much. Next candidate.
Thank you.
Leave the mouse.
Hi,
please.
sir. Hello.
Hello. Leave the mouse, please.
May I request control?
Yes, please.
Thank you.
This patient has mid-abdominal pain. Go on.
I'm presented with axial slices of a patient presenting with mid-abdominal pain. I'd like to look from the top of the scan
It's
to the
scrollable
bottom.
for you.
Yeah, it's scrollable. Yeah, it's just a bit slow.
Use the arrows, please. Use the arrows.
Sorry, I can't seem to scroll.
By the way, my colleagues, in the exam, all the examiners insist that you must scroll. One examiner for technical errors, really, I can't scroll. And it was the worst exam, worst room for me. So try to scroll, try to do all trials. Look here, my colleague, what happened here? Could you detect anything?
So I'm presented with the CT abdomen and pelvis. I'm looking at the sagittal views. I can see that there is a focal collection in the umbilical
Yes.
region with fat stranding
Yes.
and adjacent tethering, but there is no evidence of any acute bowel obstruction and no evidence of any other features. Currently, I think there will be possible umbilical collection. I would like to ascertain if the patient has had any further history. And looking at this view, sorry, I can also see that there is a urachal remnant from the bladder extending into the umbilicus. This is probably a remnant for urachus. Patients with this appearance have an increased risk of adenocarcinoma. I would like to ascertain further the history, but there seems to be a fistulous connection between a sinus tract between the anterior edge of the bladder and the umbilical region, with a focal collection seen in the umbilicus with fat stranding is seen. So I'm concerned with urachal remnant in this case. In addition to this, I can't see any other free air, no bowel obstruction, no evidence of any abdominal free fluid. I would like to look at the axials once more to look at the bladder, but also follow up this patient with a cystoscopy. Yeah.
Thank you so much. This is a case of infected bladder apparatus. Don't forget this site finding or this film edge. See, also I hide from him the history. This patient actually has umbilical discharge. Look here, my colleagues. This is assessed. This is the arachus, which connected from the top of the bladder to the umbilicus. Okay, and when it get infected, it cause a discharge. Like the doctor said, it may predispose for a cancer, whatever the type. It is very important to detect this. Rest of the abdomen is normal. Thank you, doctor, so much. Next candidate.
Yes, sir, I'm here.
40-year-old male patient presented to the emergency department with painful abdominal mass. Go on.
Okay. So I'm provided with the radiograph abdomen and pelvis of skeletally mature patient, and I could appreciate that there is a paucity of gas noted in the central abdomen with bowel loops displaced laterally. So I'm thinking of something arising from the pelvis and extending into the abdomen. And I would like to,
One second, please.
Sir.
Request again, please, a control.
Okay, sir. So I have requested again.
Yes. Go on.
Okay. There was a mass located in the central abdomen. The bowel loops are displaced laterally. In addition to that, the liver and the spleen, splenic shadow, and the bones appear normal. I would further like CT scan to see this mass.
This is a CT scan.
Okay, I'm trying to scroll. Okay, so I'm provided with non-CT scan images with oral contrast only. First, I would like a minute to scroll the entire section and to reach up to my area of interest. I could appreciate a large heterogeneous mass located in left hemipelvis, left hemiabdomen, extending up to the pelvis, as patient has history of undescended testes. I would like to see the inguinal canal. I could appreciate right-sided. So the images are jumping. I think I saw a left-sided undescended testes. I would just like to confirm it. Yeah, the left-sided testes is located in the inguinal canal. The scrotal sac is empty. And so can you give me the contrast enhanced images, please?
Yes.
I would like a arterial or venous phase. So on the given images, I could appreciate an enhancing lesion located in the left hemiabdomen, reaching up to the pelvis. The left-sided undescended testes is also seen. So I'm thinking of this is also some undescended testes with malignant transformation. I would like to see any metastatic nodes. However, I could not appreciate any lymph nodes in the retroperitoneum or in the chest region. Sir, I would like to evaluate the rest of the viscerals for also any possible metastatic spread. But the abdominal viscerals also seem fine to me. So considering the history and imaging appearances, I am thinking of bilateral undescended testes with malignant transformation, and I would like to inform the case to the referring physician so he can do the surgical removal and the histopathology.
Thank you, doctor, so much. Really, you are brilliant. But you leave the mouse.
Yes,
Leave the mouse. But this is only undescended left testis. Please leave the mouse. Leave the mouse.
I have left.
Because here the right testis could be seen here. This is the see at the last. This is the right testis. At the last cut, almost. See, I will show in coronal, especially in MRI. Patient has MRI. See my colleagues. This is the same patient, by the way. But the MRI, the CT was enough. See, this is the right testis. Okay.
Okay.
Let's look here in the CT. You did really very well when you pick up this mass here, and you did very well when you describe this almost originate from the. Okay, no problem. See, my colleagues, the displacement of the bowel laterally. So this opacity is abnormal. She asked for CT. This is the venous post contrast. This is the large retroperitoneal mass here. Look here, my colleagues. You will find this pedicle. Look here. Look. It is connected to the inguinal. Look here to the inguinal region. Here. By the way, this is not the undescended testis. By the way. Okay? Okay, my colleagues. So this is the seminoma, large seminoma of undescended testis. This one of the left side. In the MRI, much better. Here, look here, my colleagues. This is the lesion. Look here at this cord, like, see? Just go down here. Here at this side. Anyway, if you tell the examiner it is a large retroperitoneal mass lesion, maybe a malignancy of undescended testis, he will be happy. Especially if you detect the site, it is a left side, not a right side, because this is the testis of the right side. Thank you, doctor, so much. You did very, very well. What type of metastasis, chest metastasis of seminoma, doctor?
Lymph nodal.
Chest metastasis. It has a characteristic appearance in case of seminoma. Cannonball. One of the cannonball is a seminoma. The next candidate, 14-year-old female patient with acute left lower abdominal pain, mild fever, and vomiting for 4 days. Hello?
Yeah, hello, can you hear me, sir?
Yes.
Sir, I have requested for remote control.
Yeah, go on.
Okay, these are grayscale. I think this is single image. This is a grayscale ultrasound image of the pelvis of 14-year-old female patient having history of abdominal pain for the last 4 days. I can appreciate that the uterus is in normal position, and I can appreciate that the left ovary as name written over it. It is replaced by a region of mixed echogenicity with areas of increased echogenicity, and few cystic areas are also seen along the periphery of this mass. I need to look for the other images, especially the Doppler ones. The contralateral right ovary seems to be unremarkable. It shows normal follicles and normal central stoma and normal size. Likely this is a case of left testicular torion. I like to see the vascularity of the left ovarian torion. I like to see the vascularity of this tossed ovary. I can appreciate few vascularity, subtle vascularity along the peripheral aspect of this ovary, twisted pedicle with, okay, there is written no vascularity. This is a case of acute ovarian torsion. As this is emergency, so I will pick up my phone and will inform the referring gynecologist and will suggest referral to the gynecology for further evaluation for further management. That means certain.
What will you do next, doctor?
Sorry.
What will you do next?
Sir, in this case, MRI can also be done to see. Okay.
This is MRI.
This is T2 weighted. These are axial MRI images of the same patient having history of left ovarian torsion. I can appreciate that there is fluid surrounding the ovary. I can appreciate again appreciate the enlarged left ovary with the increased central stoma and multiple peripheral base follicles. Few low intensity areas are also seen along the peripheral aspect. I'm looking at the pedicle. I need to look at the fat set images. I think this is coronal fat set image. Uterus is also tilted towards the tossed ovary. Also, I can appreciate that there is low intensity focus. I need to rule out any underlying mass cause this that could be cause for this ovarian torsion. I think sorry. Yeah, this one low intensity area, which I again need to see on the.
Give me your final diagnosis, doctor.
So, in summary, in this patient, there is with acute pain and fever, there is on ultrasound grayscale images, there was enlarged ovary with the increased central stoma. And also on the there was no vascularity of the pedicle on the Doppler ultrasound. And on MRI, there is fluid surrounding the ovary with again enlarged left ovary. This is a case of left ovarian torsion which needs urgent management. I was searching for any mass lesion causing which could be cause for this ovarian torsion. There was on the fat set images, I was suspecting some low intensity focus. I was in suspicion of some dermoid or.
Thank you, doctor, so much. You did very well. But try in this very clear case to take or to smash the case as much as less time or as much as rapid as possible. This is a classic case of left ovarian torsion. See, enlarged edematous, left ovary surrounded by fluid. If we look at the axial, here there are an ectopic position of the ovary, while the right ovary in its correct position. Where is its correct position? This is the vessels, just medial and inferior. Here it is posterior to the uterus. This is the uterus. Okay. So one of the most important sign of torsion ovary is the ectopic location. See, number 2, very huge. It looks like the same size of uterus. Number 3, the edema. Number 4, the ascites. Thank you, doctor, so much. Next candidate.
Hello, Dr. Rami. Thank you for this session.
Thank you. 50-year-old female patient with left flank pain and hematuria.
Okay, could you scroll for me, please, doctor? I'm using my phone.
Okay, no problem.
Let's start with the pelvis. So this is a multi-sequential MRI. starting with the axial sections of T2 weighted axial images. The frank abnormality, I can see a large lesion arising from the left kidney, evident by a claw sign. It appears well defined. It displaces adjacent structures. Can I check the kidney again, please? The left kidney. Yes. Okay. So this is a T2 coronal image. Okay, there's a large lesion showing multiloculation and diffusely hyperintensity to signal. Okay, I'm trying to check the rest of the kidney itself. Okay, its epicenter appears to be from the renal pelvis. I would like to check the T1 images as well to look. Okay, so this is T1 fat sat with contrast during the portovenous phase. I would like to check. There is no solid component or thick enhancing septi, but
Are
there
you
there
sure?
appears to be
Doc,
some.
doc,
No, I'm
doc,
not
are you
sure.
sure?
No, okay, there. No, no. There is what appears to be a solid enhancing component peripherally within the lesion. Also, there's enhancement of the septi and the wall of the lesion as well.
So,
Okay. This is an aggressive lesion, I think, arising from the left kidney. I'm suspecting a malignancy. Uh, I would
type of malignancy.
first my
Which
first
type?
differential would be transitional cell carcinoma. Second
What else?
differential would be endophytic renal cell carcinoma.
Okay,
Um, uh,
which type of renal cell carcinoma could you expect with this one, and why?
um, yeah, the cystic pattern may be related to clear cell. I think I'm not sure.
Not clear cell.
Not okay. Maybe chromophobe. I'm not sure actually. Um, okay,
Okay.
so I would like to check for any signs of metastasis or any synchronous other tumors because
What
TCC
else?
can be
What
multifocal.
else?
I would like to
What
check
else you wanted to
uh,
check about?
any complications like hydronephrosis, either from hematoma or compression, direct compression on the
What's your next
ureter.
step, doctor? What's your next
Okay.
step?
Okay. My next step would be referring this patient to MDT for if there is obstruction to relieve the obstruction and further management regarding the tumor itself. I
What
would
further?
usually characterize.
What further management do you will recommend the
Yes,
MDT to
just
do?
radiologically staging with chest CT scan. Um,
What
PET
else?
CT usually doesn't help in this case. Um,
What
okay,
else?
excretory images. I would also check the excretory images.
What else?
If not available on MRI, I would order CT urography.
Hmm. What else?
Okay. Regarding the management part,
Could you think the MDT is recommended to take a biopsy or not?
no, 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 no. Biopsy should be avoided because if it is renal cell carcinoma, there would be spread along its tract.
Thank you so
So
much,
this
doctor. You
patient
did very well.
needs mostly radical nephrectomy because the lesion is large and xiphotic, and there may be some peritoneal enhancement and thickening adjacent to it. So maybe it's locally advanced.
Thank you, doctor. You did very well.
Most
This is
welcome.
a renal cell carcinoma, but look here, less enhancing than the kidney itself. Look here, my colleagues. The tumor itself, this is the kidney. This is a very bright kidney tissue. But here, see, this is the kidney, the tumor itself, less enhancing. So overall, this is a renal cell carcinoma, but this is a papillary type, and this is the tech of today case. Papillary type is less enhancing than the kidney in comparison to the clear type of RCC, the clear type, which is a hyper enhancing. That is the tricky or the trick of today. You forget, doctor, to tell me about the invasion of renal vein, this one, and IVC. This is very important and very critical. My colleagues, for any renal mass, even you suspect it is a benign, tell the examiner either the renal vein is invaded or not. Very important because it will completely change the management plan. Completely, you can't imagine. It may transfer the patient from operable to non-operable. Not only for the renal vein, but I'm talking holistically, renal vein and IVC. Very important. Thank you, doctor, so much. Next candidate.
Thank you.
Good evening, sir.
Next candidate ready?
Good evening, sir.
Hello? Hello?
Hello.
Hello?
Hello.
Doctor, I can't hear
Hello.
you.
Hello, sir.
Hello?
Can you hear me?
Yes. Could you
Hello.
request control?
Can you hear me, sir?
Yes. Acute
Yes.
abdominal pain, 65-year-old male patient with acute abdominal pain. Go on.
Sir, I requested remote control.
Go on.
Okay, sir. So, provided of the axial non-contrast enhanced CT images of the abdomen.
Yes.
I'm scrolling through the data set before I comment. So the patient has come with right lower quadrant pain. So I'm in the right iliac region. I'm seeing isodensity, which is small in calcific density, which is seen along the right psoas major muscle
Okay.
with surrounding fat stranding. I'm just coming to the renal. There are few exophytic lesions which are involving the left upper pole of the kidney, multiple isodens lesions, and it is causing bulky left kidney. And there is another isodens nodule which is seen in the right lung base, right lung base. So there's some fat stranding along the right psoas major muscle and fat stranding. So I'd like to see the contrast enhanced sequence.
This is a contrast.
Okay. So provided are the contrast enhanced phase images of the abdomen. So first I'm going to the right lower quadrant pain, focus of region. So I'm looking for, okay, the appendix, I'm able to look, appendix is dilated with the calcific density, which must be the appendicolith, and few hypodense areas, which must be the dilated appendix and content, and there is surrounding fat stranding as well.
What else?
And also I can see there are some collection which is surrounding the appendix. So that can be content perforation of the appendix with acute appendicitis.
What else?
So I'm just going to the, and there is the appendix is entirely replaced like mass formation. Coming to the left kidney, there are exophytic enhancing focal lesions.
This focal
Which is
lesion? Focal lesion or mass?
There is a heterogeneous enhancing mass involving the upper pole of left kidney. And also the enhancing pulmonary nodule in the right lung base.
Okay. Conclude, doctor,
So,
please.
so enhancing mass lesion involving the left renal left kidney upper pole and pulmonary nodule in the right lung base and enhancing heterogeneous mass involving the appendicular region. So I'm thinking of malignant mass lesion with metastasis.
Which malignancy? What is the name of this malignancy?
So it can be one is mucinous adenocarcinoma of appendix with secondaries in the kidney and lung. Other possibility is left renal carcinoma with metastasis to lung.
Do you think this patient could be a double pathology?
Come again, sir.
Do you think this patient may be a double pathology?
So can you repeat, sir? I didn't hear.
What is the other pathology other than the renal mass?
So I didn't get you, sir. Can you?
See, this is a renal mass which
Yes.
leaves the mouth, which it metastasized to the lung,
Lungs. Yes.
associated with mild pericardial effusion. This is a mild, and this is a metastasis. And I
Yes, sir.
think liver is
So it
not.
can be
And I
right,
think
left.
there are few hepatic deposits. What about this one? This is another pathology.
Yes, sir. It can be acute appendicitis with
Okay, thank you,
perforation.
doctor. Thank
Yes.
you. Okay, thank you. I think
Thank you.
no obvious perforation. My colleagues,
Yes.
this is a case of double pathology. RCC,
Yes.
which metastasized to the lung, associated with mild pericardial effusion, and a few small hepatic hypo-enhancing lesions. See, this is one. Leave the mouse, please. And I think this is one. It may be a cyst or a deposit, we don't know. And here, the appendix. Appendix is very large, and I think it may cause a localized abscess formation, whatever. Okay, so this is a double pathology, acute appendicitis and aesthetic left RCC. Thank you for all my colleagues. I am sorry, I must go my duty now. Let's continue our list in the next session in next Wednesday. Thank you for all. This session is recorded. I will share with all of you. Thank you.